Hello, so this will be the part 3 of diabetes mellitus. I had broken this off into two parts because we are going to study about the different classes of drug for type 2 diabetes mellitus. So this video is again for my private use. If anyone else finds it helpful, I'll be grateful. So let's start. What are the different classes of oral hypoglycemic drugs for newly diagnosed case of type 2 diabetes mellitus? So the first class is biguanides, and in this you'll see a name that is metformin, which is really common, and a lot of diabetic patients in the hospital will be on regular medications of metformin, maybe in combination or maybe just metformin. So biguanides, the mechanism of action is it inhibits hepatic gluconeogenesis, and because of these drugs, HbA1c levels can fall as far as 2%, and we know the target control or the good control for HbA1c in diabetic patients is below 7%, and biguanides, as they decrease the level by 2%, it is really helpful in diabetic patients. So metformin, as we know, it is a biguanide. It comes in three preparations: 500 milligram, 850 milligram, or 1000 milligram preparations. Metformin is excreted via the kidneys. That is why we have to keep a watch on the kidney function test when a patient is on metformin. And what are the complications of metformin if the KFT comes low? It is lactic acidosis. So earlier there was a drug in bag-o-nides which is known as fenformin, which came before metformin, and it was banned because it caused the complication of lactic acidosis even if the KFT of the person was normal. We stop the metformin if the estimated GFR of the person is below 30 to 45 ml per minute, which is I think grade 3 CKD, or serum creatinine is more than 1.5 milligram percent. So yeah, it is 30 to 45 ml per minute is grade 3 CKD, but if you are not sure, you can just check it. The side and the better criteria for seeing the complication of the effects of metformin is to check the estimated glomerular filtration rate. The side effects of metformin are nausea and vomiting, vitamin B12 deficiency, so it can cause macrocytic anemia, and lactic acidosis. Metformin is the drug of choice for type 2 diabetes mellitus in obese patients because metformin is weight neutral or a weight loss drug. So it is really helpful in obese patients because they can also lose weight, or at least they will not gain weight. The drug of choice in type 2 diabetes mellitus in obese patients with nephropathy is DPP4 inhibitors like linagliptin, glipizide, and tolbutamide, because and the, it is metabolized by the liver. The linagliptin is metabolized by the liver. So this was just a small fact. So let's continue with the biguanides and the complication. So lactic acidosis can be of two types, type A and type B. So type A lactic acidosis can be seen in diabetes mellitus with septic shock. So in this type there is shock, so there is decreased oxygen perfusion, and it is seen in diabetes mellitus with septic shock. And type B lactic acidosis can be seen in diabetes mellitus and due to metformin or fenformin. But fenformin is banned now, so I don't think you'll see that a lot. Now, the second class is sulfonylureas. Patients generally have better compliance with sulfonylureas, and sulfonylureas also decrease the HbA1c level uh, by the same percent, that is 2%, and it can cause hypoglycemia, so it can be considered a side effect. And the mechanism of action of sulfonylureas is it is an insulinogenic drug, so it will cause a burst of insulin in the body, and the burst of insulin, because there's a lot of insulin, there'll be a increase of sensitivity of the receptors. Uh, the drugs in sulfonylureas are the glipizide, glyburide, and glyclazide drugs, and you have to do mealtime regulation in these, and that is why these drugs have better compliance. Now the third class is thiazolidinone, which mechanism of action is it is a it increases the blood flow receptors of the muscles and the adipose tissue, and it will decrease the serum triglyceride. The HbA1c level fall due to this drug will be 1%. In this class, the two drugs we know are rosiglitazone and pioglitazone, and patient will generally have good compliance with these drugs. But the thing is, these drugs they increase cardiovascular mortality. That's why the drug is contraindicated if the patient also has congestive heart failure or coronary artery disease with diabetes mellitus. And there is also an instance of increase of bladder cancer with these drugs. Now, the fourth class of drug is alpha glucosidase inhibitors. These drugs are taken with the meals, and the mechanism of action is it inhibits GIT absorption of sugar. So, as there is less absorption of sugar, like most of us can already think the side effect is going to be diarrhea. So, the side effect in this drug is osmotic diarrhea. So we give acarbose, voglibose, and miglitol because these three drugs, even though they are alpha glucosidase inhibitors, there is a lower incidence of osmotic diarrhea with these drugs. That is acarbose, voglibose, and miglitol. Voglibose, if you work in the hospital, voglibose is a really commonly used drug, and many patients are prescribed voglibose as a regular medication. The HbA1c level fall due to alpha glucosidase inhibitor will be 0.25%, which is very less compared to bigonides, sulfonylureas, or even thiazolidinones. And the use of glucosidase inhibitors is usually to control the postprandial spike of sugar. So in diabetic patients, the sugar level will be low, but after they have a meal, the sugar level will really spike up. So like if after a meal you take an RBS, their blood levels will be like 300 plus. So to control that spike, they are given alpha glucosidase inhibitors, which they have to consume with the meal. uh, the next class is meglinetide. So mechanism of action of meglinetide is also the same as sulfonylureas. It is an insulinogenic drug, and because of being insulinogenic, it increases the sensitivity of the receptors. The T half life of this drug is 1 to 2 hours, and there will be a postprandial. It is used for postprandial sugar spike control, just like alpha glucosidase inhibitors. And the drug in this class is ending with glenide, so ripaglenide and nataglenide. Uh, if you work in the clinical setting or doing internship, you'll see many patients are using ripaglenide as a regular medication, and ripaglenide is a meglinetide, and it is also used for the postprandial sugar spike control. Now the next class of drug is DPP4 inhibitors, or that is dipeptidyl peptidase 4 inhibitors. So what these drugs do are there is GLP-1 in our body, which is the glucose linked insulinotropic peptide. It is responsible for sending the sugar into the muscle and the adipose tissues. So what happens is the DPP4, that is the enzyme, that is dipeptidyl peptidase 4. It is responsible for the degradation of GLP-1, which sends the sugar into the muscle. So we can realize that degradation of GLP-1 is not a good thing in diabetic patients, and this the DPP4 acts after 2 hours and it will degrade the GLP-1. So DPP4 inhibitors will inhibit the action of DPP4, and as DPP4 degrades GLP-1, there will be no degradation of GLP-1. So in this class, that is DPP4 1 inhibitor 4 inhibitors, There is sitagliptin and linagliptin. Linagliptin, as we saw earlier in that extra fact, it is used in obese diabetes, obese type 2 diabetes mellitus patients with nephropathy, because linagliptin is metabolized by the liver. The other drugs were also metabolized by the liver, but in DPP4 inhibitors, linagliptin is metabolized by the liver. And there's also sitagliptin. Actually, these DPP4 inhibitors, sitagliptin, in a clinical setting, it will be very common. Like if a diabetic patient is admitted, like many a times he will be given a combination medication with the use of sitagliptin. So we can see why it is that used. The and there is also incretin, a class of drug called incretin, whose mechanism of action is slightly different. It increases the production of GLP-1. So here DPP4 will be allowed to degrade GLP-1, but there will be a lot more amount of GLP-1 because of these drugs in the class of incretin. So they are like exenatide and liraglutide. They are injectable drugs and they are only given once a week. The side effect of these drugs can be hemorrhagic pancreatitis, but it is found out to be very rare as a side effect. And as a side note, we should learn there is a insulin that is given once a week, and that insulin is called icodec. Uh, and now the other class of drug which is very common, like many people would have heard about it, is SGL2 inhibitors. It promotes the loss of sugar in the urine. So like even without reading, we can already assume, like if there is loss of sugar in the urine, there can be bacterial growth in the urinary tract because of presence of sugar. And as we all know, bacteria loves to have food around them, so there will be a side effect of risk of urinary tract infections. But SGL2 inhibitors, they are helpful because they decrease cardiovascular mortality. As we learned earlier, there was a drug which increased cardiovascular mortality. It is thalidinon. Thazilidinon. I'm sorry if I'm pronouncing it wrong, but that was a drug which increased cardiovascular mortality and was contraindicated. But SGL2 inhibitors, they decrease cardiovascular mortality, but the risk of UTI increase in these drugs because of the loss of sugar in the urine. And the most common and the drug in this class is canagliflozin, and canagliflozin is a really common drug for diabetic patients. So let's study what are the drugs that are useful in both type 1 diabetes mellitus and type 2 diabetes mellitus. So there is a drug called pramlintide, which is the best drug to be used, that can be used both in type 1 diabetes mellitus and type 2 diabetes mellitus. Acorbose can also be used in both, and of course insulin is also can be used in both type 1 and type 2 diabetes mellitus. Now let's see what is the treatment or management for type 2 diabetes mellitus which is recommended. So if the HbA1c level of the patient is less than 9%, we will use monotherapy. So monotherapy is lifestyle modification. So like eat less ghee, butter, no red meat, and like you can only eat white meat, and then you should do exercise 30 minutes a day for 5 days in a week, and no alcohol, no fast food, and that all. And a drug which is metformin, which is in the class biguanide, and it will be responsible for the fall of HbA1c by 2%. If the HbA1c level is 9 to 10%, we'll use dual therapy. So we'll use metformin, which is a biguanide, plus SGL2 inhibitor like metformin and canagliflozin. There we can also use triple therapy, which is metformin plus SGL2 inhibitor and acarbose. So SGL2 inhibitor, we know there's canagliflozin, so we can say triple therapy is metformin, canagliflozin, and acarbose. But if the HbA1c level of the type 2 diabetes mellitus patient is more than 10%, we'll use combination therapy. And like we read it before in the part 1 video, like if the HbA1c level of the patient is more than 10%, we have to use insulin. So we will use subcutaneous insulin, but we'll give two drugs that are metformin, and we can give, or like we cannot give SGL2 inhibitors, depends on the other things of the patient. Like as we know, SGL2 inhibitors, they increase the risk of UTI. So maybe if the patient is already at risk of UTI, then we will not give SGL2 inhibitors. But at least, but insulin is the mainstay of treatment, and metformin. So in insulin, there are different types of insulin, and there are insulin which are used in different types of diabetes. So we saw it is used in type 1 and type 2 diabetes mellitus, but it is also used in type 1.5 diabetes mellitus, which is called MODA. Okay, and in type 2 diabetes mellitus, if it is the HbA1c is more than 10%, and like in later stage of type 2 diabetes mellitus, it is sometimes refractory to all oral hypoglycemic agents or drugs. So refractory means like if you give more medications to reduce the HbA1c level, it will not reduce. Instead of reducing, the blood sugar level will increase. So that is when we will use insulin in the patient. That is in the later series of type 2 diabetes mellitus. Uh, it can also be used in acute hyperkalemia, in diabetic ketoacidosis, which can be more commonly seen in type 1 diabetes mellitus, and also in non-ketotic hyperosmolar coma, which is more common in type 2 diabetes mellitus. If the patient is having acute hyperkalemia, diabetic ketoacidosis, or non-ketotic hyperosmolar coma, we'll give regular insulin, but not by the subcutaneous route, but by the intravenous route, because we need a fast onset of action. Okay, so type 1.5 diabetes mellitus, it is known as MODY. Sorry, not MODA, MODY. So maturity onset diabetes in the young. So it is an autosomal dominant. It is autosomal dominant, and the peak onset of this type of diabetes is at 25 years of age. Until that age, it is asymptomatic. There are 6 types of MODY, so MODY 1 to 6, but the most common is type 3, and in this, the insult is on the chromosome number 12 on the HNF1 alpha gene. So in this, there is insulinopenia, and there is beta cell mass of the patient will be normal, but in there is insulinopenia, but the beta cell mass of the pancreas will be normal in the patient. So the every generation of the family will be involved. So I've just made a schematic representation. So in type 2 diabetes mellitus, you can see like the grandfather has diabetes mellitus, but his son, the father, will not have, but his grandson, or like this patient, will have diabetes mellitus again. That is type 2 diabetes mellitus. But in MODY, all the generations of the family will have diabetes mellitus. So the grandfather, the father, and the grandson all will have diabetes mellitus. And if you do radioimmunoassay, the insulin levels in MODY will be low because there is insulinopenia, but in type 2 diabetes mellitus, RIA always comes high. So here is a comparison of different type of diabetes. So in type 1 diabetes, the RIA will radioimmunoassay of insulin will be low. In type 2, which is the most common type of diabetes, the radioimmunoassay of insulin will show high at first, but then it will show low. In type 1.5 diabetes, the radioimmunoassay will show low insulin levels, and MODY, which is the rarest type of diabetes, the radioimmunoassay will again show low. So what about the beta cell mass in the pancreas? So in type 1 diabetes, the beta cell mass is reduced, but in type 2, first the beta cell mass is normal, but then there is exhaustion of the beta cell mass in the later stage of type 2 diabetes. In type 1 1.5 diabetes, the beta cell mass is again reduced, but in MODY diabetes, the beta cell mass is normal. So what are the mechanism of action of these types of diabetes? So type 1 is an uh, autoimmune mechanism of action is autoimmune. The type 2 is polygenetic inheritance, and like you cannot really pin out what is the main cause. In type 1.5 diabetes, there are two type of antibodies we talked about, that is anti-GAD and anti-ICA antibodies. And in MODY, which is the rarest type of diabetes, there is a insult on chromosome 12, it is autosomal dominant. On chromosome 12, it is the HNF 1 alpha gene. So what are the treatment for type 1 diabetes? We know the treatment is insulin. For the type 2 diabetes, the most commonly used treatment is biguanides, metformin. For type 1.5 diabetes, the treatment is glipizide, and for MODY, the treatment is again a sulfonylurea, which is called glipizide. So at this point, I'll end this video because I think it is already way too long. And again, this is just for private use, but if anyone finds it helpful, I'll be really grateful that I could help someone in their studies. So I hope you find it useful. And next, we'll cover the long-term complications of type 2 diabetes mellitus. So I'll make another part for that, but this ends here, and I hope you will remember all the classes of the medications that we talked about. So thank you for watching.